going to be doing the talk on the basic science. I'm a intercalated student with Plymouth, doing a critical care intercalation. So I've been based over in the Royal Stoke Intensive Care Unit for the last 6 months. And these are slides that have been delivered at Leeds Hospital. These are slides that have been adapted from a series of talks that have been done at Leeds Hospital. So, sorry, let me get this going. So we have a disclaimer. I'm going to read through it. This series aims to introduce many of the fundamental concepts relevant to COVID-19, including the relevant underlying physiology and clinical management strategies for COVID-19 patients. These presentations are not designed to provide guidelines for definitive clinical advice. They are based on current best knowledge, but this is a rapidly evolving field. Always follow local guidelines and recommendations. And the presentations do not reflect the opinions of the contributing institutions. So I've tried to keep this as up to date as possible, but my apologies if for whatever reason the information isn't correct or is out of date. And I would like to just put the disclaimer that I'm a medical student, not a virologist or an intensivist. As Blair has already mentioned, that we're trying to support Devon Air Ambulance as part of this. So if you can, it would be very much appreciated, I'm sure, and they do some fantastic work. So without further ado, what we're going to do today is we're going to talk through some of the terminology related to COVID-19. We're going to have a look through the pathology and talk a bit about the pathophysiology. I'm going to try and keep it basic, so my apologies if it's too simple for you, and my apologies if it's too difficult. It's quite difficult because there's quite a spread of different backgrounds. And we're going to also try and talk about some of the strategies for reducing the risk of infection. Let's talk about terms first. So you'll hear a lot of different terms being used, but these are the terms that the WHO recommend, so the World Health Organization. So COVID-19 is the disease, and then SARS-CoV-2 is the virus that causes the disease. So they're the correct terms according to the World Health Organization. Prior to it being agreed, I've just got a pop-up saying what the breakdown of students is. So prior to the World Health Organization agreeing this terminology, you may have seen it referred to as NCOV, 2019 NCOV, but this nomenclature. Why do I say that? So here is just a picture of all the families of viruses. And over here, you can see the coronavirus is one of the members of one family of viruses. So a lot of news places have referred to it as the coronavirus, whereas actually it's probably better to be calling it COVID-19, just because actually there are lots of different types of coronavirus. So the SARS-CoV-2 virus is an enveloped RNA virus, and we'll talk about what that means later, so don't get scared by that. There are other coronaviruses that affect humans, so you may have heard of the SARS outbreak or the MERS outbreak, or actually you are probably likely to have had a cough or cold that's been caused by a coronavirus at some point in your life. So the COVID-19 virus, where did it come from? So at the moment, the suspicion is that it's come from what's a wet market in Wuhan. So a wet market is where lots of live animals are generally sold for meat, and the virus is looking like it originally comes from bats, and then there was probably an animal in between that, and then the virus jumped from the bat to the animal in between to humans. So how is it spread from human to human? So the main way that it seems to be spread is in respiratory droplets, aerosolized particles, or those droplets being on contaminated surfaces, and then people then touching their eyes or their mouth. And the reason this is important is to do with PPE. So respiratory droplets are best stopped usually by a surgical mask, whereas aerosolized particles. And what I mean by that are particles that are really, really, really small and sort of suspended in air. And actually, in order to filter them out, you don't need the surgical mask. You require a FP3, or you might have heard them referred to as N95 mask. This is important because the current guidelines from the government for what protection you should be using depend on the likelihood of procedures generating aerosolized particles. So we'll be talking all about the interventions in later series, in our later series of talks, but stuff like CPAP and intubation, high flow oxygen are all aerosol generating procedures, and so they're requiring FP3 masks as opposed to just a surgical mask. So let's talk about the pathophys. So with this, I'm going to start from quite a basic level, so my apologies if it's too simplified. So to the left, you can see, I'm going to see if I can get a pointer, so if this doesn't work, my apologies. Yeah, so to your left, you can see a sort of very simplified picture of the coronavirus. So round here, this is RNA, so that's genetic material, and it's a very easily read form of genetic material. And then you've got an envelope protein going all the way around, and then on the top, on the outside, you've got what are called S proteins, and these are really the key to how the coronavirus gets into your body. So in the middle, you can probably see that we have a diagram of the respiratory tree. So at the top, you've got your larynx, your voice box, then you've got your trachea, your windpipe, and that splits into two, and then it splits again about 20 times. And then right at the end, you've got something called alveoli, which are literally sort of sacs filled with air where gas exchange happens. So moving over to the final picture on the right, you can see a cross-section of an alveolus. So the capillaries are labelled, they're your small blood vessels where the gases exchange into. Then you've got your alveolus, and then you've got two real types of cells that in the alveoli, what are called your type 2 alveolar cells, or you might hear them referred to as pneumocytes. And so type 1 pneumocytes and your type 2 pneumocytes. Type 1 pneumocytes are just really, really flat cells to allow gas to pass over them. A squamous epithelium, if you like histology. I've yet to meet someone who does, but they exist, I hear. But type 2 pneumocytes are cells that produce something called surfactant. And we'll talk a lot about that later on. But basically, surfactant stops the alveoli from collapsing due to something called surface tension. We'll talk about that a lot more when we talk about ARDS. So why do I mention this? The coronavirus really affects these type 2 pneumocytes. So the S protein binds to the ACE2 receptor on pneumocytes. And then once it gets into these cells, it basically takes over the cell and uses that cell to make loads and loads of copies of itself and then release them out. Now the type 2 pneumocytes know that this isn't what should be happening, and so they release a load of sort of warning chemicals out, and we call them pro-inflammatory cytokines. So I'm not going to go into all of them because there are a lot, but basically they have a few effects. One of the effects is to slow the blood down and to make blood vessels leaky. So that allows all your immune cells to go into your alveolus and start fighting the bug, but it will also cause a lot of complications as well. And we will be talking later about ARDS and how we ventilate that. When I say later, I mean later on in our series of lectures. So please do come and tune into that. So what's the effect of this? Sorry, let's get this. So, sorry, I'm still finding my way around Zoom. There you go, marvelous. Okay, so on the left, you've got another picture of an alveolus, and it's filled with pus, and that's happening because all the immune cells come in and some fluid comes in and they start fighting the coronavirus, and that causes what we describe as consolidation. So if you've ever seen an X-ray, a lung X-ray with white opacification, so white patches, that can be caused by consolidation. The X-ray above it is a picture of a lung with pulmonary edema. Specifically, it's a COVID patient, and they've got something called ARDS. We'll talk about that later on, but that's due to fluid from the leaky vessels. So you can imagine this causes a real problem with reduced oxygen levels in your body. It also produces coughing symptoms that we see, and it can cause patients to have to really increase their work of breathing, so they come in really short of breath. Below we've got fever, and that's really a product of those warning chemicals that I mentioned, so your pro-inflammatory cytokines. They're basically causing the body to increase the temperature, and that can be helpful to an extent because it allows the immune system to mount a response, but above that then it can cause some complications. Top right you can see a picture, and this is to do with something called a nose, I can never say it. So basically they're reporting that about 30% of COVID patients are noticing that their sense of taste and smell has gone, and that's quite an unusual way for things to present, and some patients are reporting that as their only symptom. And conjunctivitis is another symptom that's been mentioned. This is not an exhaustive list, but this is me just sort of trying to simplify the pathophysiology of coronavirus. So moving on. So incubation and transmission rates. So the average time from person getting infected with COVID to them showing symptoms is about 4 to 5 days. However, there's quite a wide range within that. So in some cases, they're reporting up to 14 days before symptoms show. It's important to note that coronavirus can be infectious before the symptoms show up. So you can have people who are out in the community doing their normal daily routine and actually spreading the virus without them knowing. And the coronavirus has something called an R0 value of 2 to 3, depending on what study you read. So what's that? I'll try my best to explain that. So in the middle, we've got a diagram. So in this diagram, where you've got an R0 of 1, you can see one patient. So imagine a patient gets infected. If the disease has an R0 of 1, that means that patient will spread the virus to one other person, and then that will go on to spread to one other person again. The coronavirus, as we've mentioned, has an R0 of between 2 to 3. So every patient that's infected, it would likely spread to 2 to 3 people. So you can imagine very quickly that causes a big problem. So this is just quite an interesting infographic. So you can see that one person infects, they've gone for 2.5 people, and then if those people then spread at the same rate, after 30 days you have 406 people with the infection, which is phenomenal. And if those people then go on to spread, you can see how quickly things like this can spread. Now, just for comparison's sake, the flu has an R0 value of about 1.3. And actually, when you think about the severity of... Sorry, the flu has a value of about 1.3.
No, it can't.
Sorry, Blair, I think we're getting some people just cutting in, if that's... so flu 1.3, and that causes a lot of problems. So an R0 value of between 2 to 3 can cause a real problem, and that's some of the reason between that's some of the reason for the self-isolating. Okay, so COVID-19, there's a huge range of symptoms and presentations, and that the presentations and the likelihood of different outcomes really is is quite varied amongst age groups. So the statistics and the percentages do vary, but they're saying about around 20% of people who get the disease are completely asymptomatic. Nonetheless, they can still spread the disease, and that's another reason that we're self-isolating. Most people will get a mild common cold-like illness, which some people are describing as like the flu, but that will resolve. About 15% of people are requiring hospitalization, and then about 5% are requiring ICU support due to ARDS, sepsis, and multi-organ failure. So there are particular groups that are at risk, more at risk, so older ages, and then those with comorbidities, so those with underlying health problems. So this is a study, this is basically a model from China on the left-hand side, using data that they had from their outbreak. And you can see on the y-axis, so the axis going up is the mortality rate. So 0.01, 0.05 even is a 5% mortality rate. 0.1 is a mortality rate of 10%. And then on the bottom, you've got age. And you can see as age increases, the likelihood of dying as a result of COVID increases. And it's important to mention that this doesn't mean that those people under 50 are completely safe, but it means that the likelihood is a lot less. On the right, you have a diagram that shows very much the same thing, but the data is from South Korea. And South Korea had a very sort of robust, quick response because they've dealt with things like the SARS outbreak before and the MERS outbreak. And even then, they're seeing about an 8.2% mortality rate in those over 80. It's worth pointing out, though, 92% of 80-plus-year-olds are surviving coronavirus with those statistics. So it's very easy to look at those statistics and think, oh, wow, but also just 92% of people are at over 80 are surviving. And it really depends. There is a graph that I've not put on here that shows that different comorbidities really influences the mortality rate that you have. So this is really fresh data. Don't be put off by the tables I'm showing you, but this is for the minority of people who are ending up going to ICU. This is data from ICNARC, which is the intensive care network across the UK, and it's showing people who are discharged from intensive care, so people who have finished in intensive care. So the data will likely change, and it's well worth checking it out if you're a bit of a data nerd, because it does help put things into perspective. So if a person's admitted to critical care, the current data is suggesting if you're requiring organ support, that 50% of people are sadly not surviving their intensive care admissions. So the second box down, the second red box, is showing people who are having to have advanced respiratory support. And for those of you who are interested in what this means, we're going to do a talk on that in next week. You'll have to suffer me talking about that. We're going to do a talk about that next week, so please do tune in for that. But it's showing that actually in patients so far who have had COVID, 67% of people who have sadly not survived as a result of having to have this. But it's really important to stress, though, that this is preliminary data. This will probably change. But if you look at the final box at the bottom, there's a real difference in survival rates depending on how old you are. So those aged 16 to 49%, those aged 16 to 49 are surviving, 75% are around 75% are surviving to discharge from intensive care. But in the 70 pluses, that's dropped down to 30%. So there's a real variation in age, and I think it's worth showing you this data, just because it's important to sort of underline that intensive cares are really sort of, there's quite a lot to cope with if you've got a lot of COVID patients. So this slide is borrowed directly from the Leeds presentation. I've not really changed it at all. So children are a group that seem to be getting it relatively few cases. Now there have been a couple of cases reported of children sadly not having really severe cases of COVID, but actually a majority of children get quite a mild illness. However, children don't really stay away from other children, and that's the real problem, is that children often live with people who have comorbidities or older people, and that's been some of the sort of logic between the closing of schools, is actually it's hoped that that will slow the spread of the infection. Then talking about pregnant women, there's not been a huge amount of data published on that. If you're interested in finding out about it, please go to the Royal College of Obstetrics and Gynecologists, because they've got some really, really good explanations and summaries of the evidence. But the data so far isn't too bad. The data that I've seen has been okay in pregnant women, but I've not sort of looked at the issue particularly much. So I'd really implore you to have a look at the ARCOG information. So you'll be pleased to know that we're getting very near the end of the presentation. So speaking about what can we do to protect ourselves? So what is the risk from coronavirus? How do we reduce the risk? So we've already talked about the transmission being from respiratory droplets when they're either in the air, and they can be aerosolized, or they can be on surfaces. So we've talked about masks and surgical masks and FP3 masks. But let's talk about surfaces. So the really important thing with surfaces is cleaning these surfaces and making sure that we are really vigilant with our hand hygiene, because it's just a case of making sure that we wash our hands regularly in order to minimize the risk of getting something from surfaces. And it's really important that we try not to touch the mucosal surfaces, so eyes, mouth, nose, because that seems to be one of the entry points for coronavirus. There has been some indication that other bodily fluids may pose a risk. So there's quite high levels of the virus in fecal samples. However, whether or not that can then result in transmission, I couldn't see much about that, but be aware that could potentially be a risk. Okay, it's worth remembering asymptomatic individuals pose a risk, and I've said atypical individuals. That's not just people who are weird. No, that's people who don't present how you would expect them. And I'm speaking to some of the clinicians that have spoken about coronavirus have mentioned some cases where people didn't look like they had coronavirus but actually came back as positive. So not always have that suspicion, but be aware that these patients can present differently from how you would think they would present. And also remember that healthcare workers can get it in the community as well. So when you're out shopping, washing your hands is a very pragmatic step to take. So there is a study that basically tried to replicate real world conditions in a lab to see how long these viruses can survive. So it was saying that on some surfaces it can last 2 or 3 days, and it can be viable for up to 5 days in air-conditioned environments. So that really reinforces the importance of cleaning surfaces and making sure we wash our hands. So for those of you who want specific PPE guidelines, every trust will have guidelines, and the Public Health England have produced basically tables of what PPE to wear in different contexts. So we talked about high-risk procedures, so those that are aerosolized, and they will require different PPE to say just seeing patients on a ward where there's no suspicion of COVID. So if you're interested in what you need to interested in what PPE that you need to wear, this is a really good website to be looking at, and that's just typing in Public Health England PPE for COVID. So, summary: COVID is a clinical manifestation of the SARS-CoV virus. So it's a real spectrum of disease, and I've mentioned a lot of cases where I've sort of mentioned cases that are quite extreme. So I've talked about the people who are requiring intensive care, but it's really important to remember that only a small proportion of patients require higher level care. Transmission is primarily through respiratory droplets, and that virus can last for a long period. So here's some quite helpful links for resources and some references. If you want to get the links, there is an you can get an electronic certificate for this session. So if you follow this link and then give us your email address, we can send a certificate, and we can also send a copy of the slides if you would like. I hope this has been helpful. I'm trying to leave this QR code